Also, you'll see that everyone is muted in the audience. So there is a Q&A function if you look down at your screen, and you can use that to put questions in, and we'll address those questions with the panelists through our discussion at the end. Also, the chat is disabled, so make sure to use the Q&A function. So we're going to now have 3 speakers who have joined us, and really I want to welcome all of them. They will each talk for about 10 minutes about this important topic, answering the question of what it means to widen our responsibility beyond access to include social and environmental context of patients and citizens, particularly at this moment in time. The first person that is going to address this is Penny Dash. And Penny is very well known in the UK, across the health community, and in Europe. She's a senior partner at McKinsey, and she leads on healthcare in Europe. She's had an extraordinary career of really making change, working, advising, collaborating with organizations such as the NHS and beyond, in really helping them to shape and improve their healthcare. So without any further ado, I'd like to turn it over to Penny to really start the conversation and as our first panelist in addressing this important topic. Penny, welcome.
Thank you, Nora, and hello everyone. Delighted to be joining you. I should just say, and Nora and I haven't caught up for a couple of months, I did actually retire from McKinsey at the end of August, and I'm now chairing the North West London Integrated Care System, which, as many people would, with a wry smile, recognise that I now need to try and implement much of the things that I've been advising and talking about for the last 20 years or so. For me, it's a real pleasure, but also, I recognise the significant challenge in changing my role. The integrated care system in North West London essentially has responsibility for the health and well-being of 2.4 million people who live in that patch. And the role is really to try and bring together all of the players. That includes everything from employers through to a whole host of startup organisations, universities, local government, healthcare providers, and so on, to really think about how do we improve the health and well-being of the local population, as well as, of course, to ensure that we provide high quality services, and to do all of that within a defined budget. So it's by no means a small challenge, and I'll weave together a few sort of pieces of research and analysis that I did at McKinsey before I left, as well as what it actually feels like now to be playing this role for real on the ground. So what are some of the challenges that we face? I mean, many of you will have read lots of things, and others speaking today, particularly Michael, far more expert in talking about some of the health challenges that populations face. But if I try and summarize it, we have, over the last 100, 200 years, we've seen really quite dramatic increases in life expectancy. That is now starting to tail off. So that is one challenge. The second is, while that is starting to tail off, what perhaps is even more important is that years of life lived in healthy life, or quality of life, is really slowing down at a greater rate. So even when people are living longer, they're not necessarily living those years in good health. And the third significant challenge is around inequalities. So in my patch of London, we go right from Buckingham Palace all the way out through Wembley, through Brent, out to Hillingdon, Hounslow, and it gets quite leafy and affluent again. So we really have some very, very stark inequalities. You can measure those inequalities any which way you like, but whichever way you look at it, your life chances, your quality of life chances are significantly lower if you were born and brought up in some parts of Northwest London than if you were born and brought up in other parts. And of course, over the last year, COVID has really exposed those inequalities in a very dramatic and significant way. Now, the really interesting thing is then when you come into this role to say, well, what do we do about it? And also, what's your case for doing something about this? And there's clearly well, I personally think that there is a values case here that I personally don't feel comfortable living in a society with that larger an inequality, that larger difference, and knowing critically that we could do something about it, and we could do something about it right across the broad range of society. But also there's an economic argument here. And often health and healthcare services are seen as an economic drain. You can hear that today in announcements about the budget. But actually, if you look at the impact of healthier populations on our economy, then having a healthier population, having a population that can contribute more to the economy and for longer because they're in better health, actually has a significant economic gain. And the analysis I did when I was previously at McKinsey, which any of you could download the report, it's called Prioritizing Health. We quantified there was a $3 trillion economic gain just in Europe from improving the health of the population. And that's not improving way beyond what we've got. That's just essentially, just to adopt the term, it's leveling up. So if we could level up, we would actually have a significant boost to GDP, which would, of course, then allow us to invest more in improving the health of the population. So our argument was that health should be seen as an investment, not as a cost. So what could we actually do, though? And this is the really interesting thing for me. It's very easy to talk about these challenges, but then, suddenly I find myself in a role where we need to do something. And the piece I find quite interesting is it's easy to talk about the inequalities gap. It's easy to talk about the health challenges and so on. But when you sit down with a group of people who, in theory, their job is to actually do something about it, and you say, well, what do we know? How do we actually think through what are the actions that would have an impact? The room actually goes quite quiet. Or people come up with a whole set of things, but can't necessarily give you the evidence base or the analysis behind that. So one of the things I'm trying to do is trying to sort of force us as a collective group to say, well, what are the things that we need to do? And if I try and share with you where I think we are getting to, but this is, we're not going to do this over months. This is likely to be years. But of course, we need to get going. We need to start. It largely comes down to 5 things, which I'll try and summarize. So the first is we absolutely need to recognize the social determinants of health. I won't go into that in detail. I presume others are going to pick up on that. But we know that probably the biggest determinant of those inequalities in health is around employment level, is around education level, is around housing, transport, clean air, and so on. So the first is we have to work with our wider partners to address some of those things. And there's a lot of interest in trying to do that. We need to shift from interest into real actions. The second thing we need to do is almost go back to public health basics. And my observation would be that some of the things, I was a public health doctor many, many years ago, some of the things that I think used to happen, I don't see happening quite as much. And I'm not sure whether that's because people don't believe in them or whether we've sort of taken attention away from them and so on. But, we have some quite worrying figures around everything from smoking cessation services through to weight management services, through to supporting women to breastfeed, through to screening services. So our sort of public health armory, as it were, about supporting people to adopt healthier lives, supporting people to increase the rates of breastfeeding or go along to screening programs and so on, we seem to have had a bit of a lack of focus on those. So I'm trying to rekindle some of that. That's the second thing. The third thing is really looking at the way in which our health and care services work. And I will talk about health and care. So within this, I'm including social care, both adult social care and children's social care, mental health care, community care, and primary care. Those services are, people would recognize, pretty fragmented. They are not always run in the most efficient and effective way. They do not take a population health perspective, i.e. they don't say what's the population that we're trying to look at, look after, support, what are their needs, how do we address those needs, how do we do so by working together, how do we do so by ensuring that we are providing high quality and efficient services. that sort of rigor in terms of thinking through what is the best way to deliver services is not quite there. And if you look at the data, it's very, very stark that the people at some of our poorest, most deprived populations absolutely get the poorest services. So we really do have an inverse care rule where the quality of primary care in particular is worst in the poorest parts of the patch. So there's a really big challenge there to try and make change, try and make improvements. But of course, some of the things that we have in place prevent that. The fourth thing that we need to do is to look at our acute services. So well over 50% of the budget goes on hospitals. Those hospitals absolutely have scope to improve. We do not have good rates of utilization of our expensive diagnostic kit or of our hospital beds. And we have an estate which is not particularly fit for purpose, but is also very poorly used. So it costs us a lot of money and we don't use it very effectively. So if we add all of those things together, you know, that's 4 big actions that we need to do. And then there's a whole set of things that I'm calling enablers. So how do we use digital technologies? How do we use data? How do we think about the workforce of the future, both in terms of offering employment opportunities, but also making sure that people are working in the most efficient and effective way? And how do we bring in innovation, new ideas, academia, and so on to support us on this journey? So that's a very quick run through, but hopefully that starts to set the scene in terms of some of the things that could be done. Thank you.
Thank you so much. That's fantastic. And it really does set the scene. And I think addresses much of what we're seeing, particularly here in the UK. So next, I want to go to Ankur Saran. He's a professor at the prestigious Indian Institute of Management in Ahmedabad. He is a professor of public systems and has written and published extensively, and most recently about women's empowerment and income inequality in India. So Ankur, I really turn it over to you to give us a more kind of international perspective and what you're seeing in your patch, as it were.
Thank you, Nora, and thank you. Like I mentioned to you, it is really a privilege to be speaking on the same panel as somebody whose work greatly shaped my own doctoral journey. So thank you for giving this opportunity. I will be bringing in examples primarily from India because that's really the context that I'm working in. Now, in a developing country context, you know, one typically imagines, and I'm not trying to devalue any of that imagination, that the primary responsibilities are that of access and that of, you know, providing basic healthcare facilities. But if you look at India in particular, and you see India as being an exporter of not only vaccines, medicines, and a whole range of other health services, coupled with us struggling to climb up the nutrition ladder, coupled with us sort of, you know, ending up at the bottom in terms of rankings in nutrition, you see paradoxes, and you see very cruel paradoxes in some ways. And these paradoxes in some ways point to these social and environmental factors that influence health. What I'm going to try to convey here, and I'm going to try to do that with a couple of stories, is that these relationships are getting even more complex. And the conventional categories that might have aided us in terms of trying to formulate interventions are changing, and are changing fast. And the only way to respond, and this is sort of going to be my solution side of it, that you know, we need to think about decentralized, devolved systems which respond in fairly nuanced and customized ways. And that may be the only path ahead as far as you know, trying to address some of these social and environmental factors. So I'm going to work with a presentation, more to just to refer to it. I hope you can see that. Now, I'll begin with a story that I was not really expecting to hear, but it's a story about vaccine hesitancy. And I was out there waiting for my child to come in his school bus. And the security guard, the security personnel started talking to me in a very agitated manner, asking me, why is government forcing us to take vaccines? It's threatening us that we will lose our jobs. We will not be allowed to take trains if we don't take vaccines. Vaccines have never been compulsory, then why now? I tried to respond. He was fairly dismissive in terms of my, whatever I could offer to say. He described a video that seemed to have sort of had a fairly deep influence on him. A video that was obviously shared in some social media site run by some large corporate somewhere. And this video foretold, he argued, what he believed was happening, that there would be vaccines, that they would be made compulsory. And this was all, and this is where it starts getting really interesting and maybe even worrying, that this was all supposed to be a way to wipe out the poor. Now, this is no typical rich against the poor story. It had a new motive. And the motive was climate change. And he said that, look, the narrative that he was conveying was, climate change is such a big issue now. The elite, in some ways, have come to this realization that there's nothing that they can do to escape the consequences. They can't buy themselves out of this, and the only way ahead is wiping out the bulk of the population. He saw COVID as sort of an attempt to do that, and the failure of COVID was now being substituted by vaccinations. Now, he then went on to name, institutions, medical professionals, talking about RNA, that the virus is of an RNA type, and that these viruses are supposed to be difficult to vaccinate against. And having survived this serious case of COVID himself, so it's not like he was unfamiliar with what COVID could do. He warned me, you can come out of COVID, but you will never be able to come out of what the vaccine does to you. And despite all my education, all the reading, all of that, I have to admit, there was a shiver that ran down my spine after this conversation with him. The reason I point this out to you is because it complicates many of our conventional categories. It complicates these categories of educated, uneducated, high income, low income, rural, urban. And here is a person who is actually following media, right? He's following influencers who are also followed by the very educated. So Dr. K.K. Agarwal, the person who he referred to, is also followed by some of my own colleagues who are also medical professionals. So it's not, you can't even blame, ignorance onto this hesitancy and this sort of, despair and agitatedness that he had. Now, another example of vaccine hesitancy, just to again provide some political context and what politics can do, right? Now, this is from a survey that was done in July 2021. These numbers would have drastically changed, but this is telling us what are the attitudes and behavior among Hindus and Muslims towards vaccination. Now, I'd like to draw your attention to this last bar, or the last two bars here, where they compare that the vaccine provides protection against severe diseases, not infection. Right? You'll notice that both the groups are fairly close to each other. So again, it's not like one group is less informed or more informed on something that we know to be true. But if you look at behavior, have taken at least one dose, right, or are hesitant to take vaccines, or are sure of vaccine safety, right? The distrust, right? And this is where these gaps start showing up. And this is not too surprising given the political milieu that India was in vis-a-vis particular legislative efforts that were on prior to COVID. And so you have this, a person, who's clearly a Muslim here, saying that, so it's clearly a wicked ploy to reduce our population in the garb of vaccines. Now, again, this is not necessarily new. We know we've experienced this with the polio vaccine as well. But the point is, there are contemporary factors that keep evolving. And if you don't keep responding to these contemporary factors, which are acting at a social and environmental level, we are bound to lose this game. Now, I'll go to the second story that I wanted to share, which is that of migrants. This is a hugely neglected social category, but one that came in some ways visible to all of us last year in March, when in India there was one of the strictest lockdowns that was imposed. In a matter of couple of hours, the country was supposed to shut down completely and was supposed to shut down completely for 3 weeks. The Prime Minister came and he basically said everybody has to stay where they are, in their houses. And so while people like me and we hunkered down, there were these people, right, the migrants, nearly 10 million of them, who started finding ways to go back home. And if it meant walking 3,000 kilometers, they were ready to do that. And there are stories, in fact, of people doing that. Multiple, stories of people doing that, despite all the hardships. Right? And like this person says, I will never leave my village. I will make less money, but at least I will stay alive. Now, what is going on as far as migrants go? And this is a category which in some ways, again, problematizes very easy to differentiate social categories and social environments. So I draw upon a survey that I've been more closely involved with. This is a survey that traverses the wide geography of India, all rural villages. This is predominantly low income. 25% of these households that we surveyed had a migrant member. So that means somebody worked outside. Now, the basic story that I want to share here is that we see migrants better off economically. We see migrants better off in terms of access to health insurance, right? But when I start looking at other factors and I start looking at outcomes, migrants start looking a whole lot worse. Despite being economically better off, despite having this potentially better access to healthcare, right? So whether it be mental health, whether it be sort of treatment for non-COVID diseases being affected, whether they're being sort of anyone falling sick in the last month, we don't know what factors or what was the nature of sickness, or it be a nutritional outcome like cutting down on food. Now, by themselves, the levels are worrying. And for instance, this is December. This is nearly 8 months post the lockdown, right? And we still have, on an average, 25% of the households telling us that they have cut down on food. That's a pretty significant number. But what I'm trying to draw attention here is this migrant versus non-migrant comparison. Now, what's interesting is, and these are the reasons for anxiety that migrants have. Now, what's interesting is when we start looking at what kind of social ties and access to institutions, social institutions do migrants have and not migrants have, right? We start seeing differences. And why do they matter? Because in our data, we have clear evidence, at least the evidence suggests that if you were supported, if you received support, right, it reduced anxiety for you. If you were supported by the local panchayat, the local government institution, you were more likely to be able to access social protection schemes like the employment guarantee. Now, but when we compare migrants versus non-migrants in terms of being able to get support if they needed it, again, we find migrants being less likely to be able to get the support, right? Indicating weaker and institutional ties, and which perhaps is responsible also for these worse health outcomes that we actually find. Now, we should also step back and since we are speaking about a larger context, as to what made these people want to walk these thousands of kilometers, because they had to walk. There was no other transportation that was available to them, right? 48% said no work, 23% said forced evacuation by the employer. These are the two largest categories, right? Now, so here is a role that market actors could have actually played in mitigating this adversity, right? I personally met migrants who were on their way walking back to a destination which was 2,000 kilometers away, and it was with great difficulty that we were able to turn them back. Now, I want to come to the last story, which is in terms of response. Now, it's not that even in a developing country context, we don't recognize that there are social determinants of health, right? Our largest cadre of health workers who are called ASHAs, the acronym, the ASHA, the term means hope, but the acronym starts for Accredited Social Health Activist. It's this cadre of nearly 1 million women on whose shoulders has rested a whole lot of surveillance activity, a whole lot of making sure that people are being quarantined, people are being vaccinated. There was an article by Bill Gates a couple of days ago, again praising them. This was some of the customized ways in which they were actually, trying to get the message out, right? Whether that be songs, playing, you see the dholak here, taking out a sort of a small procession in the village, trying to make people aware. Now, if you see, they don't really have any of the personal protective equipment. They don't have proper masks. They don't have gloves. And as I found out over the course of working on a project, they don't have basic sanitizers. They didn't have oximeters. And it's no wonder that despite them doing all of this, they have themselves faced tremendous adversity. Right? And this lack of support essentially means that our strongest army, in some sense, to fight this terrible disease actually was sent out without, in some ways, the equipment, the arms. So if the point that I am trying to sort of, in some sense, argue and make here is that if we recognize social and environmental factors make a difference as far as health goes, these are essential ones. We recognize the value that these women can play because they can associate, they share an affinity with the community that an outsider doesn't. But we need state and perhaps even market actors need to be supporting them a whole lot more. And in the absence of that, it is fairly difficult to be able to respond to all the social and environmental diversity that we have, all of which in some form or the other is affecting health outcomes. So I'll conclude there, and I'll be happy to take any questions. Thank you.
Thank you, Ankar. So really interesting and great to see kind of the contrast of both the kind of UK example and now India. So that brings me to our third and final speaker, who many of you will be very familiar with, and that's Sir Michael Marmot. He's a professor of epidemiology at UCL and the author of The Health Gap. He's also chaired the Commission on the Social Determinants of Health. So I'm sure he has much to say and to add to this topic. And so I'd like to turn it over to you, Michael. And thank you for joining us.
Thank you. I do have quite close links with Ahmedabad through the WHO Commission on Social Determinants of Health. And although I'm going to talk about the UK today, much of what I say in principle applies to low and middle income countries as well as high income countries. So let me start. You said, Nora, in your introduction, you talked about health care management, but in fact, as Penelope Dash said, this is not primarily a health care issue. You want us to talk about business, but it's not necessarily the business of delivering health care. The opening line of my book, which you mentioned, The Health Gap, was why treat people and send them back to the conditions that made them sick. So it's the conditions that make people sick, where business has a clear role to play. And just picking up from what Penelope said in her introduction, the challenges that we have in the UK, that over the decade before the COVID-19 pandemic, I produced a report, Health Equity in England, the Marmot Review 10 years on, in February 2020, just before the pandemic. And we documented the slowdown in improvement in life expectancy, the increase in inequalities in life expectancy, and for the poorest people in the most deprived 10% outside London, life expectancy was going down. Now, this is pretty dramatic. We're used to health improving all the time, and conditions were such that life expectancy for the poorest people was actually going down outside London. We looked at the potential reasons for that, and I thought when Penelope said that in her new role as chair of the integrated care system, when she asked people, what should we be doing? I would have put my hand up, said, I know. We produced a second report in 2020 called Build Back Fairer. And we said we do not want to re-establish the status quo, at least we shouldn't want to re-establish the status quo pre-pandemic, because it was ghastly for the reasons that we've just been saying. Build Back Fairer, I said there were 6 domains, picking up what I'd said in my 2010 review. Give every child the best start in life. Number 2, education and lifelong learning. Number 3, employment and working conditions. Number 4, everyone should have at least the minimum income necessary for a healthy life. In Britain, 3 weeks ago, between Wednesday and Thursday, the Chancellor, the Minister of Finance, removed £1,000 a year from families on universal credit, putting 300,000 extra children into poverty. I did speculate if he could do that between Wednesday and Thursday, maybe between Thursday and Friday, he could take steps to take 500,000 children out of poverty. So having enough money to live on. The 5th was healthy and sustainable places in which to live and work. And the 6th, what Penny called public health basics, taking a social determinants approach to lifestyle. So where does business fit into this? We've said, and we're now working with Legal and General, big financial company, has £3 trillion under investment. So it's not a small player. And we've been saying, and we're working with them to work this out, but we've been saying that there are, broadly speaking, 3 ways business is important here. The first is it produces things which can be good for people's health and bad for people's health. If there weren't a food industry, those of us who live in cities would starve. So we're dependent on the food industry, but it can damage our health or it can improve our health. So with everything else we talk about. So business is vital because it produces stuff, which it can be good or bad. Second, it employs people, and unemployment's bad for health. Employment is good for health, but it can also be very bad for health. This morning's news, before the Chancellor's speech, was the head of the TUC said this has been, since 2009, it's been the slowest wage growth since the Napoleonic era. That the salaries of employed people, we know it went down dramatically after 2009. They picked up, but was then flat again during the pandemic. So we're only back to the 2009 level. We lost a dozen years in terms of salary growth, and then facing inflation. So business can employ people, they can pay people, they can be, as I've just described, not have enough money to have a healthy life. or they can have enough money to have a healthy life. And then, of course, the psychosocial characteristics of work. I'm sure Jeff Bezos is very happy counting his billions. He's probably a bit happier than most of the people who work in Amazon warehouses, because the conditions of work in those warehouses is subhuman. And so the conditions of work are absolutely vital. And the third thing that business does is has an impact on the community. And we've talked in the healthcare space about anchor institutions. The healthcare institutions, they can employ local people. They're important economic players in local communities. They can have an environmental impact. They can work with others. All the things that Penny talked about that she would like her ICS to do. And parenthetically, Penny, we've been invited in by the Institute of Health Equity, by ICSs all around the country who are asking to take your first priority. What can ICSs do on the social determinants of health? So watch this space as we work with ICSs to ask, how can they address social determinants of health? But business clearly has a role to play. We don't think everything should be run by the state. We need a healthy private sector. So we need national government, we need local government, the voluntary and community sector, integrated care services, and business. And business has this key role to play in those three domains that I talked about. They're making stuff that can be good or bad for people's health, employing people in a way that can be life enhancing or life destroying, and having an impact on the local community. The ESG, in fact, working with Legal and General, the chief executive said he'd like to add H, health, to ESG. What's the impact on health? And well, if we're adding numbers or letters, I'd add E, health equity, not just health, but the fair distribution of health. And I'm delighted if there's a good economic case for investing in the social determinants of health. But again, I'm with Penny. The number one argument is a value-based argument. We shouldn't simply be counting how well we're doing as a society by the growth in GDP. We should be looking at the health and well-being of our population. And if life expectancy has stopped improving, if inequalities are getting bigger, if health, and particularly as Penny said, a healthy life expectancy for the poorest people is getting worse, then we've got a metric that our society is getting worse. It's not flourishing. And business has a key role to play in addressing the social determinants of health that are responsible for these adverse changes that we've seen. Thank you.
Thank you so much. That's really very interesting, and I've really enjoyed listening to all three of you. So I'd like to now, proffer up really the first question. So I've heard, really across all three is the importance, and particularly if we look historically, the state has played such an important role, and particularly in Europe in terms of health and healthcare. And the perception often is that it is for the state. I think, it's very provocative and very good to think about all that business could do. But how do we really galvanize business? As you just pointed out, Michael, and I think it feeds on what Penny said, and I think it's also true for India, that having businesses play a more pivotal role in terms of, all the kind of public policies and the way in which they treat their employees, the way that they perceive And I would like to think, just adding on, that after the pandemic, where we've really seen the impact that actually having 6 employees have on business, that businesses, not just for their bottom line, but would worry more about where their employees live. So my question really is, how do we get businesses to respond? Do we have to legislate it through the state because the state plays such an important role? Or are there other avenues that we can get to the place, Michael, that you've just articulated? So maybe we can go around, and Michael, would you like to start, or Penny?
Okay. Well, for my Institute of Health Equity and me, working with business in this way is new. Legal in general are very keen to bring other players in. They don't want, for a variety of good reasons, to be the only people doing this. They'd like other important businesses to be there. And so I think the first thing is we need to demonstrate what businesses led by people of goodwill can do. So before we start legislating, let's be clearer what it is exactly business can do and should do. Now, regulation, the history of public health suggests that regulation is absolutely vital. Voluntary agreements by themselves usually fall short. And so having a national living wage, if you said to businesses, all businesses, please pay everybody a living wage, some would and some wouldn't. But making it mandatory makes it more likely that it will happen. We know that when it comes to asbestos in the workplace or other toxic hazards like that, we regulate. When we know child labor, we regulate, we legislate about all of those things. I don't think we're a world away from asking the question, are psychosocial working conditions, stress at work, the type of problem where we should be looking for better monitoring, better evaluation, and perhaps better regulation. So yeah, I don't think that we should say you can't legislate or regulate. That's the whole history of improving health in the workplace. And to come back to India, as we've pointed out, one of the problems in India and in my studies in the Americas, throughout the Americas, is the high proportion of people who are in the informal sector. So they're beyond the reach of legislation and regulation. And that's clearly a huge issue.
Thank you. Penny?
So I think this is a great question, because it's really quite intriguing, particularly on the first one. There is a clear economic argument for employers to support the health and well-being of their employees. All the data suggests that a healthier, happier workforce will be much more efficient and effective at work. All of it suggests that then enables you to recruit, attract the people that you want to, and so on and so forth. And a healthier workforce will be more productive and have less absenteeism. Of course, there's an interesting thing that many healthcare organisations are actually perform the worst on some of those, which is a rather strange point. But I think there's a big role for employers, and it's interesting how little is still done by employers to support their employees. So that's one bit. The second bit on regulation, the piece I would go for, which I have to say is a source of much frustration for me, is I do think we desperately need more regulation around particularly food. I'm horrified every time I make the mistake of eating something sweet and salty and then having this urge to eat the whole blinking packet of it, overnight. I am aware I have mechanisms that I can A, read what's in the box, B, I can have mechanisms that I can stop myself eating the whole box, sometimes, not always. But many people don't have those. And yet this is what we are allowing to sort of flood the shelves of our lives right around the world. And then we wonder why we have populations that are overweight, have diabetes, are struggling in many aspects of their lives. And I find it really quite bizarre. You know, we wouldn't let people do this in other aspects. We strongly regulate things like car seats for babies. We put them through all sorts of checks and they have to meet all sorts of standards in order to protect their health. But then we flood the market with these other things that are distinctly unhealthy. You know, another example on that, I remain, you know, bemused, surprised, horrified about how much formula milk still floats around our societies, how much of it finds its way into maternity units and ends up, you know, encouraging women not to breastfeed. Bizarre that somehow we allow these things to happen, and yet we then put so much time and energy and indeed money into trying to improve people's health in other ways when we could have actually tackled some of those things. So I have to say, you know, and again, I go back to, I lived through 20 years in public health terms of saying the only way to tackle smoking was to basically to tell people and put up adverts saying it's bad for your health. None of it really worked. The minute we use legislation, bingo, most of us live in smoke-free environments.
Thank you. Very, very interesting. So Ankur, do you want to also add to that perspective? What would your takeaway be on business incentives as a versus legislating?
So I'll just take up on what Penny was talking about food. You know, one of the shocking, again, you know, I'm narrating stories here. When I stand, you know, waiting for my kids to come back from their buses, I see these, you know, these small stalls, these small shops selling these, you know, small packets of chips. And it's not even really potato chips. I don't know what really they're made of, but it's fried, it's full of salt and full of oil. And guess who's having them? It's actually the children who live on the sidewalks, right? That's the source, that's the food for them, because they're cheap, they're easily accessible, they're easily available. Not only are they buying it, what was even more shocking was I saw on frequent occasions, you know, some benefactor, you know, some person wanting to, you know, give the poor, you know, food. They coming and buying a carton of these chips and distributing it among the poor. Now, so again, it's not a question of educated, not educated, informed, not informed, right? And so clearly in situations like this, there is no option but to regulate and but to regulate hard. Even on the, Professor Marmot was talking about informality. And yes, there is a segment that is out of reach, but informality also, you know, falls very firmly in the shadow of the formal sector. So when I was sharing the story about the migrants and these, you know, the majority of them were associated with the construction industry. The construction industry is formalized, legalized, but those who work in the construction industry are not formalized, right? And through sort of various subcontracts, these workers are put in a precarious situation and informalized and therefore lacking any social security. Again, clear need for regulation. Can regulation solve everything? No, I do have some hope and believe in the voluntary sector. So in the Indian case, if you talk about, you know, we have a spectacular example of the Arvind Eye Care system, right? Now, the Arvind Eye Care system takes as its mission to eliminate needless blindness. So what that means, or what that implies, is that their customer is not the person who walks in, but those who have not walked in but need a cataract surgery done. So therefore, they do go out of the way to, you know, understand the social milieu of these patients and bring them in. Can businesses on their own imbibe such missions? Can they imbibe a vision of this nature and then work towards fulfillment of, you know, clearly socially optimal goals? Some can, all won't. And that's where I see, you know, the need to nudge them, and maybe ESG is one way, if we don't let it just get ritualized and become, you know, make it a form of rhetoric. So clearly both actors have to work together on this, and state and the government cannot, especially in developing countries, abdicate these responsibilities.
Okay, thank you so much. So that really leads me on to the next question, and maybe we can start with you, Penny. You outlined 4 things. Michael outlined a number of things that needed addressed. All of it seems quite sensible, but we all know that we've got a system, we've got stakeholders, we've got people quite invested. If we talk about our healthcare systems, whether it's in India, whether it's in the UK, whether it's somewhere else, we know healthcare workers are exhausted, they're demoralized. We read about this every day. So those enablers that you mentioned, Penny, about digital, working more effectively, innovation, I think none of us would disagree, but how do we actually, at this moment, at this juncture in history, when the need is so great, we've got a segment of our society that we always knew weren't doing well, and as Michael has clearly articulated, are doing much worse and going in the wrong direction. How do we get this thing turned around? Those enablers are great, but how do we actually put them into action in a broken system?
Yeah, so welcome to my world, Nora. So, I mean, literally what you just said is how I spend my days at the moment. So what I'm trying to do is, so the overwhelming majority of people working in and around the UK healthcare system are absolutely firefighting at the moment. But there is space, and there is some mind space, and there is some bandwidth actually for thinking through the change. And people get quite energized by that. In a world where you're just struggling to keep up, actually having permission, having a way in which you can almost step out and think about how could we do things differently. One of the things we're finding is people actually find that quite rejuvenating. It gives them an opportunity just to almost sit down, literally take a breath and think a bit differently. So there is space and there is some capacity. That's one bit. And actually it's quite energizing, as I say. The second bit is there are some, of course, very interesting things happening in and around healthcare at the moment. Lots of very interesting technologies, lots of interest in looking at different workforce models. Countries like India have really pioneered some very different ways of working and some really interesting ideas. And then there is a big bit about trying to encourage people to look outside the box and say, what else is there that's actually happening out there in healthcare, but sometimes in other industries that we could bring in and we could adopt. And many companies are doing those things. And there's a lot of capacity in all of those startup companies out there to do things differently and so on. So I think that the way forward is, one is to keep going, not give up. Secondly is to, amidst all the day-to-day firefighting, is just to find that bit of space to say, well, let's think through the future. And then the third is really to harness the innovation and the startup companies and the new ways of working and so on that are absolutely there.
Thank you. So Michael, do you have anything to add to what Penny has said as kind of how we need to get things turned around and the concerning taking these enablers forward?
Well, a question I commonly get asked in one form or another is, don't you get tired of banging your head against a wall? And my answer is, it doesn't feel like that. The thrust of the question is, you've been producing these reports for a long time now, and nobody seems to want to do anything. And my response is, that's not true. The fact that the national government in Britain over the last decade hasn't wanted to act on social determinants of health and health equity doesn't mean that nobody's interested in acting. We produced 3 reports in 6 months called Build Back Fairer. I mentioned the national one. The second was Build Back Fairer in the Eastern Mediterranean region of the World Health Organization. I was asked by the regional director of the Eastern Mediterranean region, that's North Africa and the Middle East, to lead a commission on social determinants of health in that region of the world. And they said, We liked the title of your English report. We want to call this Build Back Fairer. And then we did a Build Back Fairer in Greater Manchester report. On the 30th of June, we published it. Greater Manchester was really interested. We're working now with Cheshire and Merseyside, with Lancashire and Cumbria. We've been working with Gateshead. We've been approached by Luton. Coventry declared itself a Marmot city. There's real interest at local and regional level. And I mentioned broadly outside the UK, but within England. I've been approached by the Welsh government. I was talking to Northern Ireland last week, Scotland. So it's not the case. I don't at all feel like I'm banging my head against a wall. I feel there are people who really, really want to make a difference. And part of my role is showing the evidence that they can make a difference. It would be easier if child poverty had not gone up as a result of central decisions. It would be easier for people working at city and regional or local level to do their work. So it doesn't let national government off the hook. But there's a groundswell of optimism, enthusiasm, hope to make a difference. And we're tapping into that.
Great, thank you so much. So just lastly, Ankur, you talked about the community workers in India and the important role that they played, but also the fact that they're so under-resourced and don't have really adequate support in what they're doing. So how do you see those challenges and those assumptions? How do you see it going forward, and the kind of awareness that's being built, helping to make a difference?
So I think the good thing is you definitely see a lot more in the media about the kind of work that they have been doing, especially over the pandemic. And hopefully that raises larger awareness. I've been personally involved since the last 6 months in a large scale project. We've raised over resources worth £400,000 to get very basic material to these community frontline workers. And we've got support of corporates, we've got support of individuals, and we are working again across the geography to do this. And one reason that we are trying to do this is because in the process, we are hoping to raise awareness in these quarters about frontline workers. One of the things that again, speaking very personally in terms of, we know what in some ways the government should be doing, which is to provide more resources here. But what I try to do is when I teach my classes and I have an opportunity to, I definitely invite a frontline worker, a community worker to come in and interact directly with the students. Even if they don't do it in the language that the students are most comfortable in, just that personal interaction, just that being able to hear it firsthand, what are their own experiences, changes perceptions. It changes how people view them, and I think those are sort of it's going to take time, but those are perhaps the only way forward in terms of mobilizing demand and asking for change.
Thank you so much. I've really enjoyed all of it, and it's so important. And I think my takeaway, and I'd hope that those listening to this webinar take away, is that there are a number of challenges, and they cross the globe. But by vocalizing those challenges, by championing those challenges, we can make a difference, and there is an opportunity to make a difference. And so I really thank all three of you as courageous leaders who are out there really trying to make a difference on behalf of all of society. As Penny pointed out, it's good for everyone. And I think it's that message that we need to really hammer home, not just to ourselves, but to our business leaders and of course our governments, because I think the state does and will continue to play such a pivotal role in shaping society, and it must reflect, the society that it represents. So thank you so much. I appreciate all of you joining me, and those who've listened. I hope you will join us again. We've got another event coming up next month on wearable technology and the future of healthcare. So it's on the 24th of November. But again, thank you, and have a lovely evening. And thank you to Michael, Penny, and Ankar. Take care. Bye.